There we go. Hi, everybody. Thanks for being with us today. It's Friday, October 30th. It's time for you to take a break. Yeah, I know some of you said you moved it from 11 to 12, and yeah, I did. And people on the West Coast are saying, how come you can't do something for us? I'm doing, doing what I can. And I figured I'd do this for somebody's lunch hour. So it's the East Coast. And yeah, right now we're doing this on Fridays because it gives me enough time to kind of reflect on the week and to help you. Because this isn't just a treatment planning webinar. Right? Yeah, we're going to go over some things. And it's important that we go over some things, but understand that the perspective that we're taking is the director of dentistry perspective. Now, most of you are periodontists. There are other specialists here, but there's some general dentists on here too, which is fine. But understand this is being directed towards the specialist. And why? I mean, you're there, and you know what it's like in specialty dentistry and what's happened with referral patterns and things like that. And I'm suggesting that referral patterns have a lot to do with the way dentistry is going. And some of you say fortunately, and many of you say unfortunately, and I don't care whether it's fortunately or it's unfortunately. It's what it is. And to the degree that we can change things so that the specialty practice can do better and the patients do better as a result, then I think that's a pretty good game, don't you? Yeah. And so that's the game that I've been playing for a long time, and Danielle and I have been talking about it for almost 6.5 years now, about what can be done and what we can do to make you successful. These sessions are sessions for everybody who's on my list. And if people aren't on my list, then forward the link to the people that you know that aren't on my list. These are going to be free sessions. Yeah, I'd love it if you joined the IDS. But these sessions are for people to kind of get a new orientation, for doctors, specialists, get a new orientation, or maybe to rekindle the orientation you had, or maybe to give you a new perspective, or maybe to show you that you can take the perspective that you've always had and show how you can make that perspective work, because you can. And we have. And anyway, you can. You can. It isn't just Lee Sheldon and Danielle Samela, and that's all. They're the only people that do it. You've all heard it. You know that things can be done. But if we start to do things, or we try to do things in the old way, then things are going to be done the same, or the result will likely be the same. It is a new way. It's a new paradigm. And while we talk about the business aspect of it in the IDS, here I do want to talk about the treatment planning aspect. We're going to get some business in this too. So you'll get a lot out of this, or at least it's my intention for you to get a lot out of this. So I just want to paint a picture here that shows you that in fact you can do better in front of your patients right now and help the referral source if you're in a referral model, and if you choose to augment that model by being the primary care practitioner referring to the best restorative dentist, hey, that works too. The ultimate is the quality of care. The ultimate is also the ability to communicate with patients and communicate with patients to produce the best result. Because after all, I don't care who it is that's watching this right now. That's what we all want, right? And so that's where we are. That's where this program is going. That's what I intend on giving to you, and I'd love your feedback. To the degree that we get feedback, then we tailor these to you. Right now, I'm planning on doing this every Friday at 12 noon Eastern time. And for those of you who are on live, you're now going to get a CEU from the Oral Reconstruction Foundation. We thank the Oral Reconstruction Foundation for doing it. Those of you watching this on YouTube, no, unfortunately, can't do it. But those of you on live, and are on live for the bulk of the webinar, because I Zoom allows you to keep track. I know how long you've tuned in. Then you're going to get a CEU. It'll take a few days to get it, but you get a CEU every week. Next week is the AAP. Still be doing it at most of the AAP is being done on Saturday and Sunday. There are corporate forums done on Friday, and we may interfere with a corporate forum a little bit, and that's okay. Attend the corporate forum if you choose to do so. Attend us, and then go to the corporate forum if you want. If you choose to do so, that's up to you. And the idea is just to keep this going, to provide relevant material that you can apply. Some of the things I'm going to talk about are weird, or they'll seem weird. They're really not weird, but they'll seem weird to you. The only way you'll know whether they'll work is how. Yeah, that's right. You've got to try them yourself. You got to see whether they work. And if they do work, that's great. If they need a little bit of tweaking, well, you just let me know what tweaking they need or what didn't work, and I'll try to come up with a suggestion at the next webinar. So feedback, Lee@directorofdentistry.com. Just write to me. Let me know, and I'll do the best I can to help you. In the director of dentistry concept, we are in charge of the patient's care. Now, the general dentist will say, well, we're in charge of the patient's care. And you're right, you are. And we're in charge of the patient's care too. There's no reason why we can't be co-equal in planning this together. Patient comes to see me, and this is even when we were a referral practice, and most of you know we're not a big referral practice now. We get some referrals, but we're mostly direct patient care. People came to see me when it was a referral practice, and what I do, I would do the same thing I always do. I treatment plan from start to finish. I treatment plan restorative dentistry. I treatment plan everything. General dentist fits himself or herself into that treatment plan or revises the treatment plan as he or she sees fit. But the director of dentistry is the one who writes the script. It's the one who's the architect. It's the one who's the director. And as soon as you write things down, you become the director. No reason why you can't write a script. And if you write a script saying step 1, step 2, step 3, step 4, step 5, step 6, step 7, you've increased the value to the restorative dentist who's referred to you, or the restorative dentist that you're referring to, as well as the patient. Because you're no longer fitting into a box that's been defined by somebody else. You're co-equal. You're working together. And planning is a big part of working together. Got a plan. Can't just say, all right, this is my corner. I take care of this pocket. There's this recession. I need to build it up, or I need to cover it, cover the root, whatever it is. A lot more than that. You know, there are plenty of people, plenty of patients out there who need our services. And there are a number of people who said, well, who do you do a full treatment plan on? Who do you choose who you're going to do a full treatment plan on? And what do you think the answer is? Everyone. Everyone who walks into the office gets a full treatment plan. Now, if they don't need dentistry, their full treatment plan may very well be a prophy, okay? So, I mean, a full treatment plan can go anywhere from up here to down here, depending upon what they need. But everybody gets a full treatment plan. Everybody likes a full treatment plan. The patients appreciate a full treatment plan. It sets the tone for a conversation. It's, all right, when do I have to do this? Rather than it not even be recognized that it needs to be done, whatever the it is. We talk about thinking skills preceding technical skills. It's true. You know, there are a number of courses out there, a number of things that are sold in order to be able to build up, well, to improve life for the patient and to build things up. So we've got grafting techniques, and we've got different machines that do different things, and big marketing for some of these machines and for some of these techniques. But that comes and goes, it has its hot period and then it goes down in terms of popularity, in terms of attractiveness. But thinking, that never goes away. And the better you improve yourself, improve your ability to think, the better you're going to be for your patient and for the referring dentist. And that's a constant. That's a reputation builder. That's a magnet to bring people into your practice, whether they're referred by doctors, referred by patients. It's a big magnet. When you get to my age and you've developed that magnet for a period of time, and people say, well, I want to see Dr. Sheldon because I've heard thus and so. It is a magnet that pays off. I know some of you are 30 and 35. You're saying, all right, I'm worried about paying my bills tomorrow. And I got that. By the way, this will help you pay your bills tomorrow too. But the long-term approach, which has to do with thinking, doing best for the patient, and not necessarily be painted in a box by somebody else, increases your value. To the degree you increase your value, that allows you to compete on an even plane with all, or maybe a higher plane actually, with all of those who've said that they can do it themselves, or all of those have said that, represented themselves saying, we do a better job, or whatever it is. Okay, advertising is advertising, but performance is performance, and it is your reputation you're building right now, whether you're younger, and if you're older, you want to take advantage of the reputation that you've built in order to attract more patients to your office. So it works at any age, the techniques that we're talking about. Well, today I talked about what? I want to talk to you about the fully edentulous case. So let's go to that for a moment. Okay, so let's talk about the fully edentulous case. So the case is about to be fully edentulous. See what we can do to be able to help improve the life of that patient. And all I have to do is be able to push the button and maybe things will go forward. There we go. Okay, so the intake call. So KLD takes the call. The patient is interested in implants and also trying to become established at a dental office. And of course, the patient is in some way seen our advertising, our Google reviews, whatever it is that has attracted the patient to our office directly. So he's scheduled at that time at on Wednesday, September 23rd. I just saw him earlier this week, so apparently that he had to change the schedule or whatever it is. So that's the intake call. Now, patient calls back the next day, and somebody else at the front desk takes the, and she's brand new, by the way, and she called to confirm her appointment, asked if we were oral surgeons, and she explained that we do extract teeth, okay? We're training her, okay? We would train her to say, no, we have periodontists, board-certified periodontists, and of course there's surgeons who do that kind of work. So there's going to be a different answer, but the patient is still coming in, which is the bottom line. That's, of course, what we want. Okay, now the next step is the doctor call. So those of you know the IDS sequence of treatment. What we do in our office is that the patient calls, and then I call the patient. Usually I'm calling the patient, but sometimes the other two doctors in our office do the calls. But I see the bulk of the new patients in our office. Make a phone call. So make a phone call to the patient. For whatever reason, I didn't make a phone call. Either I was lazy, I didn't do it, the patient didn't answer, whatever. There was no doctor call that was made. There was no notes on the chart. Usually, even if I call and the patient doesn't answer the phone, or if I leave a voicemail, I leave that in the record. So for whatever reason, that doctor call never happened. Okay, so now the patient comes in and the assistant talks with the patient and makes notes on the conversation. This is before I ever get into the operatory. So the patient comes in, and our protocol is take blood pressure readings, do pH testing for those people who have who are prone to caries. We do pH tests on everybody now. Take full X-rays and a CT scan on everybody. Okay, so that's except if the patient's 16 or 17, I don't do that. But if the patient has major needs, then or has needs, which is the bulk of our patients, then everybody gets a CT scan. Okay, so the patient had cancer with 38 shots of radiation, 2017. The neck just below the right jaw. Patient takes care of his 8-month-old granddaughter starting 2 months ago, and it has changed his life. So notice where the conversation is. In this case, he wanted to share his life. It's important to him. He was in a dark place prior. Patient wants to make his life the best that he can. He feels he can gain a lot of knowledge going through he gained a lot of knowledge going through the process of cancer. He was in the ICU for 5.5 weeks. He had hallucinations. He felt like they were poisoning him, restrained. I mean, he was going through a lot. Running through the halls naked. I mean, can you imagine somebody sharing this with a dentist? And I know some of you are saying, well, I don't want to see that patient. Yeah, okay. There are a lot of patients we might not want to see. But a lot of patients who, once they get into an office such as yours or such as ours, finally say, here's a place where I can go with confidence. So, yeah, there's some patients I'll reject, but I certainly didn't reject him for this. So he went through anxiety, depression, put himself in jail in his own home in order to protect himself and protect his family. Then on Memorial Day, his daughter-in-law took him back to the hospital with a blood pressure of 220 over 122. He was able to return to a normal state with support from his family and his wife. Most of all, his granddaughter being born, the baby needed a caregiver, and the patient had a purpose. And then he straightens out. That's an interesting story, isn't it? You know, it was down and out for what appeared to be years. And then the granddaughter's born, and he now needs to get his life straightened out. Interesting story. Okay, so let's take a look at the patient, and we'll look at the CT scan. We didn't take a full muscle series on this patient. We kind of knew in advance where it was going. So let's look at the CT scan, and you'll see what happens. Because I'm doing the CT scan, I'm reviewing this in front of the patient. And I'm defining the bone. I'm showing the patient where the sinus is. And I'm starting to make some measurements here so I can say, hey, we can put an implant right here. So you've got a lot of bone below the sinus. So we can put implants. For most people, you can't even put an implant here without touching the sinus. For you, we can. So I'm going to put an implant right here. That'd be the first implant you put in place. And, I'll say the minimum width that we need for an implant is 5.5 millimeters. Look at the amount of bone you have. So we have a length of 18 millimeters. And we look at the width, and I'll do the sample width. I don't know what it was on the previous one, but there at that particular level, it's about 8.8 something or other. Okay. Yeah, I had to put on my glasses on. 8.83. Okay. However accurate that is. So this guy, he has a lot of bone. So the first thing I'm doing is giving him reassurance. And I'm going all the way through. And I'll put the implants into every location and just show where the implants are going. I'll do this fairly quietly. Once I've defined that the minimum width we need is 5.5 and minimum length we need is 9, because I don't like to do 7 millimeter implants, then he's pretty much with me, and I just might say, here are the numbers. But I'm just doing these measurements quietly. Okay, easily. And we take these measurements, and we let the patient see where the implants could potentially go. Okay, now I'm designing this as a 5-implant case. Most of our maxillary mandibular implant cases are 5 implants. Sometimes we'll put in 6. Almost never put in 4. And just show them what's there. lot of bone. We all want cases like this, don't we? Okay, so now let's look at the mandible. And of course, when we go to the mandible, the reference marks are changed. So on the maxilla. So anyway, we're scrolling through. You all just saw the mental foramen on the left side. And again, doing the same thing. And I know this is slow, but you know, there's no reason to rush this examination. I've got a half hour with the patient. Yeah, a half hour with the patient. You said, I've got an hour for the patient. You're doing this in a half an hour? Yep, I am. And if you have hygienists doing the examination, you can do it in even less time. See, because of the quality of the time that you're with the patient. Do some of my examinations go a little bit longer than a half an hour? Yeah, they're scheduled a half an hour. But sometimes they'll go longer, but sometimes they won't. Take a look at this abscess right here, and I'll say, here's an abscess. It's a trapped infection of the bone. That's what that tooth is doing. That tooth is draining bacteria from the root into the bone, and it's causing the bone to be lost. And we just go and just do the same tracing. And the eyes are on me the entire time. Not on me, on the x-rays. Okay. And we've got a big screen, a 40-inch screen, so the patient can look at it easily. So we can go all the way through this and show the patient what can be done and where the implants can go. Yeah, I know I'm going to play this out in its entirety. I know you may be bored, but we've got one more implant to go. There's a foramen right there. Oh, we don't have quite enough room. Let's back up a little bit. We're telling the patient we're going to back up a little bit. We're going to move one of those implants. So we're back up to where the foramen is, and now we show the patient here. Now we found enough bone. Now it's 11.87 millimeters. Now it's 12 millimeters, whatever you want to call it. Now we have enough bone right there. So we can do it. And that is the first part of the exam. Now, the second part of the exam, I'm going to do live. Okay, so if you'll indulge me. Let's go to the Anatomize software. Okay, love this software. So from our DICOM slides or DICOM images, we automatically get this reconstruction. The reconstruction looks really, really good. I'll show you what the reconstruction looks like. Most of you have seen this. It's nothing new. Okay, so here's a reconstruction. And if we look at it just every once in a while, I'll fool around. There's the Halloween view, and Halloween is coming up tomorrow night. So we fool around with that. Sometimes we'll use it. If you know, for our patients who need soft tissue grafting, usually the roots are very prominent. They can see how prominent the roots are by looking at the profile there. And so, yeah, we'd say we're using a CT scan in every patient. Yeah, we're using a CT scan in every patient, except for kids. And if kids need major stuff, of course, we'd like the CT scan as well, but not as a rule. So we showed this, and we can look at this view. So now let's put some implants in here. Okay, so I'm just going to put a series of implants in real fast. And I'll just put them across like this. And the assistant's next to me saying, see, Dr. Schultz is doing the surgery in your mouth right now. Doing the surgery in your mouth right now before he ever does surgery. Now I don't do surgery anymore. Dr. Furtado does all the surgery, but here it is, doing all the surgery in the mouth. So here I am, putting in 5 implants. Huh, that's pretty good. Okay, now that's not quite good enough. That's general location, but now let's position the implants and see where they're going to go. So we're going to take this implant, we'll put it in right here. Sinus is there. See how far back we're going to go here. Oops, don't do that. Actually, it's a little bit too far back. I wouldn't want an implant that far back. It's a little bit difficult to restore there. Okay, so we'll just move it up, move it in the correct position, and continue to move it up in the correct position, showing the patient that, in fact, take a look. There's plenty of bone here. You see, this is the size of the implant. Look at all the bone that you have around the implant. I can't tell you how many people have been told, oh, you don't have enough bone for dental implants. You know that.
You've seen those patients too. And of course, a CT scan was never taken. Some are going to ask, do you have to take a CT scan in every patient? Yeah. All right, what if I don't have a CT scan? Then you arrange with your local radiology facility to have a CT scan taken and get that CT scan taken before the patient comes into the office. Well, who's going to pay for it? You're going to pay for it. If you're not going to pay $100,000 for the CT scan, you'll pay the radiology facility $150 for the CT scan. It'll be the best money you've ever spent. Because now you can do this the same way I'm doing this. Now, would I choose to do that? No, I choose to buy a CT scan. But some of you are saying, oh, I can't afford to do that right now. Well, that's fine. You get a CT scan done at your local radiology facility. Maybe they even have a CBCT. Maybe they don't have to have the radiation from a spiral CT. But, you know, get this data. If you want to do the cases, you got to get this data. And you've got to show the patient this. And once you have the CT data, you can buy the Anatomize software for whatever it costs, $5,000, whatever it is. And you can do the same thing. As long as you have a decent computer, and I hope you have a decent computer. You have a decent computer, right? Yeah. Okay. So, but you have to be able to do this. And yes, on the posterior cases, very often we'll angle the posterior implant because usually we don't have enough room. And it also increases the size of the occlusal table. On this patient, we wouldn't do an angled implant here. But we're just showing the patient what occurs. We take a look, and the implants line up fairly good. If we look at this implant, well, maybe this implant ought to come out a little bit. Maybe we ought to move this implant out a little bit. I can tell you this, on a patient like this, I'm not going to do it now, but I very seldom will put an implant in the anterior region. Why? Because the teeth are going to come out here and the implant's back there. Why the heck do I want to have that much zirconia from the labial position to where the implant is? So I'm going to try to free up 7 through 10 as much as possible, because if you take a look in the posterior, I hope you don't make a liar out of me right now. Let's see. Let me look at this from a lateral perspective. Yeah. Well, you can see it to some degree. Usually the posterior implants line up better in a spatial position than the anterior implants. Here, everything is a little bit lingual, isn't it? But if I went to this implant here, I put this a little bit lingual. I can move this out facially quite a bit and use a multi-unit abutment and approximate position, which is this is pretty close to where this is. Okay, so anyway, we can do that. This is a preliminary implant design. Of course, we're going to go to our design software for the surgical guides and things like that. Those of you who are using a product that's similar to InSequence or, by the way, we're going away from InSequence a bit now. And just so you know, we're going away from InSequence. Having done, we don't use InSequence itself, at least we don't very often, because we have our own laboratory technician who can do surgical guide design, does metal surgical guide, and does a beautiful job. And so we can work with a local technician and do it right here. And it's nice because that local technician is on site when we do our procedures. We got to tell you, we're getting away. We're getting away from surgical guide software. Why? Because we're committed to the position of the implant that we've designed on the software. And the software itself doesn't measure bone density very well, does it? You know, so when we were doing surgery, I was doing surgery initially, I could pick the best bone. You know, if I drill a hole and I'm drilling it into what's essentially balsa wood, I can move that implant, or I can change and I can drill someplace else and put the implant in the best position possible. You can't do that when you're using a surgical guide technique, because the surgical guide, it's all pre-programmed, okay? So you've got your bone reduction guide, you've got your implant placement guide, and everything is is predetermined, and so you're not able to physically feel where the best bone is. You don't have that opportunity. So we're going back a step. We're going to see whether by doing it the old way, whether we might have better success rate, fewer implant failures. So stay tuned on that one. We'll let you know how that's going. But we're doing that, and then we'll make the impression, and either we'll fit the temporary prosthesis at that visit, or we'll have the prosthesis made in a 24-hour period of time and put the prosthesis in, temporary prosthesis in a day after the implants are placed. So anyway, didn't expect me to give you that information, did you? Okay. So let's go to back to the PowerPoint. Okay, go to Anatomize. So this is something that bothered the patient as well. And that was, he said, you know, I don't have enough lip support. I want to have more lip support than I had before. And this is a place where you, as a specialist, particularly the non-prosthodontic specialist, you can shine. You can shine. So you do that with this, a piece of rope wax. Okay. And what you do is you take the rope wax, you know, I told you it'd be less than a penny, maybe it's less than a nickel, I don't know. And you start to put that on the teeth. So let me get closer. You start to mold it. Okay. I don't know. Well, you can see that because I can't see me very well. Hey, hang on. Let me get out of this for a second. Okay. So I'm adding labial bulk. And I might do that. I know it's gross. The heck we're dentists. In the cervical area as well, and start to sculpt. You get the idea. And now ask the patient to look in the mirror and say, what about that kind of lip support? Don't look at the teeth, okay? And tell the patient, don't look at the teeth. What about that kind of lip support? And the patient might say, well, that's too much. Okay, well, let me push it down a little more. What about that? Okay. I'll get rid of this thing here. What about that? The patient looks in the mirror and says, yeah, I like that bone support better, or I like that lip support better. Sure. Can I do anything more? I say, well, take this away a little bit. So I'll take this away a little bit. Take away the wax. Okay. Whatever. Start molding it until you've got the wax in the position you want. How do you know? What do you do with that then? Well, then take a perio probe and measure through the wax. So go through the wax to, in this case, with the patient, he was wearing a denture. So you're going through the wax, horizontally through the wax to the labial surface of that tooth, say tooth number 9. And you say, all right, I'm going through that wax by 2 millimeters. Therefore, your suggestion is to the general dentist, based on your examination, the patient wants his teeth to be 2 millimeters more labially prominent than they were before. In this case, the patient wanted to add an incisal edge as well. And so I said, well, what about this? And it's difficult to see it in wax, but I suggested maybe for try-in purposes, maybe an additional millimeter. So it'd be incisally longer by 1 millimeter, and it would be labially thicker by 2 millimeters. Is that going to be accurate? Yeah. Patient liked his lip. I'll show you the picture in a second. There's wax all over my teeth. Wow. Okay. So you got the idea. Have you become a director of dentistry at that point? Well, you found bone that the patient didn't know he had. You've taken the denture and you've said, all right, what don't you like? And the patient says, well, I don't have enough lip support. And you show the patient how the patient gained lip support, and that we can set, or your general dentist can set, or the prosthodontist can set the teeth in the correct position. Look at what you're doing. You're providing tools. Yeah. And that's the idea. Director, coming up with innovative plans that the patient has never seen before, or innovative strategies that the patient has never seen before that are valuable to the patient. This isn't fluff. What I just did certainly wasn't fluff. So try it. Okay. Everybody has rope wax. If you're periodontist, you don't have rope wax, get some rope wax. It's cheap. And don't get the red stuff. Get the clear stuff. The red stuff is just going to, is going to confuse the issue. Get the clear stuff or the white stuff. I don't know what this is, but you can see it. And use that and see how well that works, and try it. Okay, let's go back to the PowerPoint. So we do that with this patient, and there are the denture teeth. And so there we put the wax on there. And now we say, what about that lip support? He likes it better. I think it's a little bit too labially prominent, but he likes it better. So there's the before, there's the after. It's not a big difference. But you can see it's a difference. And now the patient can communicate. And now you can communicate with the general dentist and actually give the general dentist a valuable tool. I probably said that already, didn't I? Yeah, I did. Okay. Now the next step is this. And I use my phone and I dictate into my phone. I dictate right in front of the patient. Okay, now some of you don't use transcriptionists. I don't know why. If it's the expense, don't worry about it. Find a transcriptionist. If you're making notes and you like to use, Dragon Speaks, or there's a whole bunch of voice recognition software out there, and Google is doing voice recognition, and it'll probably put Dragon Speaks out of business. Who knows? Then you can go directly and dictate in front of the patient. It's the dictation in front of the patient that makes a difference. Because again, nobody's done that before. And not only that, but you're coming up with a plan that your assistant can hear, because your assistant is now going to bring the patient over to financial arrangements, that the patient hears in front of the assistant, and everybody can agree that that in fact is the plan that you want. Okay, so for those of you listening rather than watching, Thomas carries teeth in the lower arch and no teeth are salvageable. Recommendation is extraction of the teeth and placement of dental implants. We ought to do that as a stepwise procedure. Tom had radiation therapy of the right mandible. Remember, we talked about the radiation therapy, and that throws a little bit of a monkey wrench. Not a big one, by the way. Well, at least I don't think a big one. We'll find out in a second. I'll show you why. Primarily in the right cervical area and the posterior submandibular area. Now, if it's going to be right in the right submandibular area, if it's in the cervical node area, do you think that's going to interfere, that radiation is going to interfere with the anterior mandible? Probably not. Probably not. But there's a way of determining that. Okay, so we'll show that in a second. So we're in the process of contacting Dr. X, the radiation oncologist, for a radiation map and for recommendations. There's the radiation map. So everybody who has radiation therapy done has a radiation map done. And the radiation map is, you can see this on the PowerPoint, okay? The radiation map is done in color gradation, so you know what level of radiation was applied to what area of the body. And then you and the radiation oncologist can discuss which areas are more vulnerable to osteonecrosis and which areas aren't. And I've had these discussions with radiation oncologists before, so that we can determine where the implant can be placed. So it's a matter of, can I see the radiation map? Okay. and then you make your recommendations. You talk it over with the radiation oncologist to determine where things where the patient won't be a considerable risk. Okay. So now we go to, he would like to have more lip support in the upper arch, would like to have an additional length of incisal edge, and I should have said an additional 1 millimeter of incisal edge, or I guess I did. I have placed some wax in the upper anterior with an additional 2 millimeters of labial support, another millimeter of incisal edge length. He should be fine. Okay. Sequence of the lower arch would be the following, and this is where, again, your director hat is there. You're saying, here's a sequence, 1, 2, 3, 4, 5, that you're suggesting to the restorative dentist. See, and if you come up with the sequence, then the restorative dentist, many will say, well, thanks for thinking this through. I may want to change the order, but at least we've got an order that I can work from, and we can work together in completing the sequence with the patient. Or the general dentist said, rather do step number 4 instead of before step number 3, whatever it is. At least you're now working from a sequence that you've established in front of the patient as a director of dentistry to be able to give that patient the order of treatment, how it's going to be done. And now your FA person, financial arrangements person, or treatment coordinator can now discuss that with the patient better. And once you've learned how to put fees to each of these, both the restorative dentist fee and your fee, you can get treatment acceptance right here. I know you may not be ready for that yet, but the fee should be established in one office. Could be the restorative dentist's office, could be in your office. I'm saying, why not be in your office? Patient's there. Patient's curious. And the last thing the patient wants to hear is, well, the surgery will be this, and you have to go to your restorative dentist to find out what the rest of it's going to be. Okay? That's really passing the buck. Okay? And you can't do that. Oh, I know you're doing it, or you may say you're doing it. You may feel that you need to do it. No, you can't do it. You can't do it. Passing the buck, or in this case, the handoff. And I don't care if it's a handoff from the front desk of the assistant or from you to the financial arrangements assistant, the handoff where the patient is transferred from one person to the other is probably the most difficult thing for the patient. Because unless the information comes from source number 1 to now source number 2, unless you have a complete transfer of that information, there's going to be some confusions that occur. It's why my examining assistant is the same one who does financial arrangements. She's seen the patient all the way through. So the same one who's doing the x-rays and doing the probing with me, doing the interview and doing the probing with me, whatever it is the same one that's doing financial arrangements, so that nothing is lost. And still something's going to be lost, but as little information is going to be lost as possible. Okay, so extraction of the lower teeth, decide whether replacing the lower denture. 2, wait about 6 weeks. Number 3, placement of implants in the lower anterior region. Note, if we are going to do a snap retained denture, then he needs lingual torus removal in both the right and left sides. We didn't go over that, but he had fairly prominent lingual tori, and there's no way you're going to get a flange comfortably over that. So if we did solid bite, which means fixed in prosthesis, what we call solid bite, then you don't have to do torus removal. At least I don't. Because we've got enough vertical bulk of material to prevent it from fracturing. We don't have to do the torus removal. Sometimes I suppose you do, but in this case we didn't. Okay. However, given the fact that he had radiation therapy, I'd prefer not to do that. Instead, I'd prefer to do a solid bite procedure in the lower arch, which would not necessitate removal of the lingual tori. And notice I'm dictating this right in front of the patient. The patient knows what I've said. The patient knows what my opinion is. Patient knows, oh, now it's going to cost a little bit more money, but now I understand why it's going to cost a little bit more money. I got to stop scratching my nose. Okay, then uncovering the implants, and I should give an interval. If we're uncovering the implants, it would be, let's say, 3 months later. I put that in there. Wait 3 months, then uncovering the implants. Then the next is fabrication of an implant-supported lower prosthesis, new upper denture with a metal base according to the above parameters. Why a metal base? Because the patient showed evidence of bruxism, and so we don't want to have an all plastic prosthesis. I'd prefer to have the cast metal base and have the acrylic placed on that. It only costs another probably less than $500 in the laboratory to get a metal base, which, by the way, allows the palate to be thinner, allows for conduction of heat. So there's a big advantage to doing a metal base. So if you haven't seen that or talk with your restorative dentist about that. Or if you're a prosthodontist on the air, talk to your periodontist about it. Or general dentist, talk with your periodontist about it, so that you're all on the same page. You can say, hey, listen, I'd love to do a metal base. It's going to be better for the patient. It fits better because you're doing a casting rather than working with acrylic shrinkage. Make it look just as good. And you've got the advantage of heat and cold conduction. Still not taste, but heat and cold conduction improves it. Okay, if you decide to do implants, there is sufficient bone in the maxillary arch for placement of dental implants on that site. Okay, I dictate that, and that's it. So these are the skills that we gain as directors of dentistry. That's what we're trying to do. That's what we're trying to give to our patients. That's what we're trying to give to our restorative dentists. If we do that, then we have started to take charge. We've started to move ourselves up to a better position for the patient, better position for ourselves. Any questions? Let me know. I'll see you next Friday at noon Eastern. Thanks.